Well, thank you, Paula, and thank the organizers for inviting me here today. You know, I have a talk which I'm obligated to give you, but I'm rather humbled here because of the talks you already heard are way better than mine. And the last one, I mean, it's like there was a guy who spoke at Gettysburg who went on for about 3 hours, but Lincoln spoke for 7 minutes, and I think we remember that one better than the other one. So my 6-hour talk will not be that good. And it's great to be here again. I was actually been around the LHINs and doing quite a bit of work in Ontario lately. In fact, it seems like I'm spending more time in Ontario than I am in Saskatchewan, which the folks back home says is a service to both provinces, but I'll let you be the judge of that. So what I'm going to do is, because I prepared them, I'm going to go through this slide deck, but most of them are not worth paying attention to, and I'm not going to spend very much time on it because there's just really a couple of things that come out of today that I want to emphasize in your journey. So this is what I said I was going to talk about, and I probably will talk about some of it, but you'll see in due course how much that I'm going to skip over. And it seems to me that to begin the conversation, just to refocus on what we're trying to do as a healthcare system. And it seems to me we want to do all of these things. And I was really pleased to hear the conversation as well about reducing population health disparities. You could say the #1 health problem in Canada is cancer, and the #2 is heart disease. But actually, the #1 health problem in Canada is disparity. That is the illness due to marginalization, disadvantage, inadequate income, inadequate social support, far outstrips the epidemiology of the diseases. And of course, the worse off you are, the more you are more inclined to get most of these diseases and so on. But if we really wanted to solve the biggest health problem in Canada, we would operate almost exclusively on the social side and economic side. Because the reality is we don't know how to make a middle-class population much healthier. We have reached the limits of what science can currently tell us about how to make the people in this room a whole lot healthier. We know what to do to make a lot of other people healthier, but we don't do it. So it's quite interesting. And you know, it's interesting whether Canadians will get their heads around that and share some of our social capital expenditures on the social side instead of grudgingly allowing governments to invest in that a little bit more. But we shall see. And just to remind ourselves, and I agree that it is important to celebrate what we do well in this country and in our healthcare system, and I think it does these things quite well. I think we are increasingly better at all of these things. If you walk into an emergency room clutching your chest, you're going to get 5 people surrounding you in no time. And that's a good thing. So if you have a life-threatening episode of care, if you have something that requires the incredible specialized talent that we have produced in our system, then you'll be pretty well served. I think it's served in at least some parts of the country as well as anyone in the world is served, and we should celebrate that. But we also do some things that aren't so good, and these are some of them. Some of them, it baffles, it boggles the mind why we persist in being so bad at prescribing appropriately. There is decision support software available for peanuts that you can install in a physician's office or a pharmacist's office computer that would eliminate a tremendous amount of inappropriate prescribing, contraindicated combinations, and so on. Yet the uptake of e-prescribing in Canada is vanishingly low compared to other OECD countries. And it baffles me as a citizen why a food inspection system that would not allow people working in McDonald's to ignore obvious safety procedures continues to allow physicians to prescribe without decision support software in their offices. And it's just a symptom of the problem that you people in this room who are such active change agents deal with. You want to change, you are intrinsically reformers, and yet you recognize that in Canada, by and large, change is optional. And that's the main message I want to talk about today, which is why is change optional in Canada, and why is the platform not seen to be burning as much as we think it is? And I fully agree with the Minister that the sustainability issue is really on the table. It's not unthinkable that we could lose this, not because of what it costs, but because of the value for money that we are not getting from the expenditures. So, a few other things that I know you have to deal with, and I think this is really fundamentally important, again, when talking about the CCAC role and in the primary care role. Somehow the system has evolved to reward hand-eye work more than cognitive work. So surgery, which is extremely important work, but it is hand-eye, very technical skilled work, built, of course, on the base of knowledge. But we reward procedures vastly more than we reward the cognitive figuring out of complex patient circumstances and the complex interventions that help people who may be frail, have some level of cognitive impairment, and have 2 or 3 chronic diseases. And it's interesting, it's probably the only industry in the world that rewards these more than this. It's quite fascinating, actually. And until we start to restore the value that we assign to the cognitive end of medicine, which is primary care in the first instance, and all of the work that people do on the front lines in social work, in personal care, all of this work is less technologically intensive, and it has more to do with looking, listening, observing, and sorting out difficult problems. And for some reason, as I said, we have let that lapse in terms of our value system, just like we have in the rest of our lives. I mean, I understand why we do it, because we are fascinated as a society with technology, but it is a real problem, and I hope we find a way at a policy level and within the funding and incentive systems that we build in to healthcare, that we can finally start to restore that balance so that we begin once again to focus on those things that are really complicated and difficult, and more to the point, meet a lot of people's needs who are badly served now. Again, we're oddly generous in some areas and oddly cheap in others. I think my own mother, just like everybody else's parents, has had some episode in the healthcare system that has left your head scratching. And a system in Manitoba that would not spend 50 cents on my mother in home care was very happy to welcome her 4 times for avoidable ER visits at St. Boniface Hospital, keep her on a stretcher for 2 days, and send her home unaided, knowing full well that she would reappear. And they felt a sense of helplessness about doing something about that, and I was so glad to hear that there are ALC strategies, there are community development strategies that at least in the high-performing parts of our system here, don't allow that to happen anymore. So this is the graph that implicitly the minister was referring to, and it is worrisome in the sense that the percentage of the GDP has shot up as a result of the recession of 2007 and 8. But the slope of the curve in the last 12 or 14 years has been steeper than at any time in Canadian healthcare history. So the spending has gone up really rapidly. And the question is, what did we get for it? And when you hear Jim Easton, you sort of hang your head in shame as a Canadian, because we didn't get what they did. I mean, they've solved their wait time problems. They have reinvented a lot of primary care. They put in place a whole lot of measures to improve the system. They began a number of the quality issues that I'm glad we are emulating and so on. And we mainly shoveled cash. Now we're starting to get better. And there's some wonderful work going on in this LHIN and throughout Ontario that is getting better. But it's not getting better as quickly as the UK got better. And again, I think we have to ask ourselves, why is that the case, and how long can we keep doing this? My province, alas, unlike yours, and in a strange historical reversal, we're rich and we're actually going to be sending you equalization payments soon, which is a source of some pride to us, as well as perhaps impending annoyance. But one of the problems is that we just after increasing healthcare spending by an enormous amount last year with midterm adjustments, have added 6.2% in the coming year. I don't think it's doing Saskatchewan's health system a favor to keep spending at this rate, because I don't think the spending decisions are necessarily going to be wise. And I think you take the accelerator off the impetus for reform when you have a lot of cash around. I think the great Canadian healthcare approach has been, when in doubt, add more money. And I think that is actually, although they don't say it so directly, I think that's what the UK experts tend to think when they see our system, that how come they can spend that much money, that much more money over an extended period of time and end up where they are. So One of the questions, of course, is integration a problem? And while, of course, the LHIN is an integrator, nowhere in Canada is the system truly integrated. I mean, for all these reasons that are listed here, but we've also, in the integration process, never fully embraced physician care as part of the system in a fundamental way. Physicians remain mainly independent contractors to the system. They may be a little bit closer to it than they used to be, but essentially we have left physicians and drugs out of integrated health systems. Since physicians drive 70% of health spending, when you have a dominant profession that is only haltingly integrated into the system and may or may not share its fundamental objectives, you have a recipe for what we have. When the quality folks say the system is designed to get what it's achieved, it's exactly right. We have not undesigned that feature for historical reasons. I think it is optimistic to believe that unless there is a closer relationship between physicians and the community in a formal way, that we are going to make enormous progress on a massive scale. The scaling up, which was a great focus of conversation today, remains a problem, and I don't think it's going to get better unless we address that issue. It's going to be very difficult to address that issue, but until we do, I think we are destined to limp along with some beacons of wonderful incremental change in certain places, but the system as a whole will not fundamentally get better. And of course, the result of that is what matters, and quality suffers. And one of the reasons why quality suffers is because we have never had a clear view of what productivity means in Canadian healthcare. We talk a good game that we want to move to an outcome perspective from an output perspective, and we want to shift from volumes to outcomes. But at the end of the day, when the pressure is on, people expect you to produce volume for spending money. And if you don't produce the volume, it means you're lazy. So if you've gotten off fee-for-service, and you look like you're not working as hard as you did when you were on the fee-for-service treadmill that we wanted you to get off in the first place, we say to you, you should shadow bill to make it look like you're still practicing like a fee-for-service physician even though we didn't want you to. It's a very mixed message. I don't know what I would do with that message if I was a physician or a family health team, but we need to decouple the notion of productivity from volume. And we also need to figure out a way to reward people who produce less when less is better. The goal of a healthcare system, after all, is not to do more, it's to do less, because we are more efficient at care, more effective at care, and we have prevented needs from appearing. So anyone who does that in the current system, by and large, suffers. The organization will lose money. The wonderful physician who manages to convince his or her patients to self-manage on a fee-for-service system will lose money. There are perverse incentives that still course through the entire system. And if we don't eliminate them, I think we're going to place providers of all kinds in a very difficult situation, and organizations. We also are much better at identifying quality problems than we used to be, but we don't really have expectations that anyone will do much about it. So we have known about variations in practice in this country for a couple of decades. 3- and 4-fold is very common. We have no system-wide strategy for dealing with it. We hope it gets better. We are delighted to support people who want to get better, but if you don't have to. And until we cease to tolerate the lack of spread of better practices, we are going to have a two-tier system of a different sort. We're going to have a small part of the system that is first-rate, and we're going to have a whole bunch of the system that is second-rate. And although I hope reporting gets better and enlightens them a little bit, I think the public is hostage to not knowing the difference. And that is a real problem that we're going to continue to face. Of course, money does talk, and everyone wants that money. Jim mentioned that in his talk as well. So the problem, too, is that every dollar of expenditure is somebody's income. And when that is the equation, we have to figure out a way to give people a reasonable amount of job security without necessarily tying that job security to a specific task in a specific place for eternity. I think it's perfectly reasonable for unions and professionals and people who work in the system to expect a stable career, but I don't think it's reasonable to insist on rigid ways of doing business when those rigid ways of doing business are no longer productive. So again, some of you may have seen this. I think this is the only graph I've ever done that I would say is a contribution in a tiny way to understanding healthcare financing. It has the virtue of simplicity. nothing else. It's not empirically derived, but I actually think it's true. I actually think when you look at all of the money we spend in healthcare, how much is at risk for non-performance? Almost none of it. So the point is we want that blue segment to shrink and the orange segment to expand. Sounds like Leighton and Harper, actually. The country seems to have already decided to a certain extent, and I mean, we're wearing the red, so it's not like we're leaving that one out. Like, thinking like Jim, gee, that shouldn't really be on film, should it? Actually, it doesn't matter in my case because I have no important role to play anywhere, so I can freelance out here. So this is the world that you already know about that's unfolding before your eyes. And again, the minister mentioned the sustainability argument. I think the sustainability argument that matters is that the system is basically affordable in the sense that societies can make a decision. I mean, if you look at that spending graph and you substituted vacation property, iPads, or computer spending, the graph goes a lot more steeply up than healthcare does. It's just that people think they're getting better value for money for those things. It's the value for money proposition that is a real sustainability issue in Canada. So, just a couple of concluding thoughts. When we change consists of two things: not doing certain things and doing certain things. So let's start with what we shouldn't do anymore. And again, this sounds pretty trite, but we do all of these things now. We actually still pay more for bad quality than for good quality. Not that we say, well, tender your services, and those of you who promise bad quality will pay more for. But money changes hands more when there is bad quality. Someone pays for the readmission, someone pays for the renewed test, someone pays for the reread of the radiology examination, somebody pays for the avoidable home visit and all that stuff. Money changes hands when we do things because we didn't prevent things from going wrong. I think it's really important, and I'll emphasize it again, about overly rewarding procedural medicine and under-rewarding cognitive medicine. When you look at the relative pay rate of a cataractologist versus a geriatrician, you have the problem defined in a nutshell. And when you realize that there are 10 times as many pediatricians in Canada as there are geriatricians, when the need is heavily concentrated in the elderly, you realize you have a fundamental problem of how we relatively value the medical profession. Coupled with that is a division of labor that is suboptimal. I bet you there are hundreds of people in this room who know more than they are able to apply in their practice because of the way the system is organized around health human resources. We educate the hell out of people, and then we only let a small number of them work at the very top of what their capabilities are. And we tend to rigidly define what people do in healthcare for a career when everybody gains a tremendous amount through experience and continuing education. I think that's unsustainable as well. And don't get me started on credential creep in healthcare, but it is a very real problem that if we don't do something about it, I think the prospects for overcoming fragmentation and inefficiency are pretty low. So, what should we do better? Well, I think we should do all of these things better. And I think the third one is particularly important. We are very gingerly entering this terrain in Canada about the appropriateness of care. As the minister mentioned, up to 30%, I think she's dead right, that we do a tremendous number of things in healthcare, either to turn a very tiny risk into an infinitesimal risk, or we do them when the evidence strongly suggests they're inappropriate. Just to give you an example, in my suddenly wealthy province, the Regina Propel Health Region has decided in its wisdom to buy knee arthroscopies from a private clinic. And never mind the private clinic aspect of it, randomized controlled trials have demonstrated that knee arthroscopies are almost always useless. And how you can make that decision in light of the evidence is beyond me, but we still do that a lot in this country. And again, it's not surprising we do it in a procedural area where you can count things, you can do things. There are people who are willing to undergo the procedure, but it may not be doing anybody any good. We've had a lot of talk today about the health information system, and I can only reinforce it. I don't think we have a hope of sustaining quality improvement without a revolution in the health information system, and I hope it happens sooner than later. Again, this is the last place that needs me to talk to you about the importance, the centrality of primary health care. But I do believe it is the road to health transformation, and if we don't get it right, we can forget about the rest of it. I think this is where change, positive change, really comes home to roost. And I think it needs to be comprehensive, community-based, scientific, as good as science can get, and very patient-centered. And again, I was delighted to hear, I wish we could bottle the physician who presented this morning on the practice in the neighborhood here about his own transformation. This is exactly the kind of on-the-ground physician leadership that we need to transform the system, and may you continue your success. But at the end of the day, again, I know that you have an impending election, and there is yet another talk of what's going to happen with the LHINs, and are we going to restructure again? I think the problem is pretty clear. Culture trumps structure any day of the week, and you can have the greatest looking org chart and structure, and it can fail, and good people will work around a structure that may be fundamentally flawed in some areas. So what we really need to focus on, and I hope the province does this, is defining performance and holding people accountable. As Jim Easton said, holding people accountable is the single biggest transformation you can make in healthcare, aside from all of the care advances, all of the systemic advances, all the health information advances that we might have. And we don't really know how to hold people or organizations truly accountable yet. I think the fact that Ontario has passed the Excellent Care for All Act is a terrific advance. You need this symbolic and legislative approval of the notion that excellence in healthcare is an aspiration and an expectation, but reality is another thing. We have defied wonderful rhetoric and excellent sounding legislation in the past in this country, and we can do it again. We're good at that. But I think finding a way to translate that into on-the-ground improvements and in a real sense of accountability is the key. So what are the essential steps to get there? You know, I have to presume to give you advice on what one needs to do. Again, I've talked about these already. I think eliminating the perverse incentives in the system, which you do not control, is really important, which suggests that one of your roles, and I say this is a role of frontline providers, middle managers, senior managers, governors, is to act at the policy level. I think you have to take a civic interest in the politics and policy of healthcare if we're ever going to get this right. There are some fundamental policy barriers to getting better, and if you mobilize, and I like that word of Jim's, that mobilize is beyond engagement. If you mobilize to change the fundamentally perverse incentives that still course through the system, you will find that your jobs are much easier to do the way you would like to do them, and it will create a dividend. The dividend will be time not wasted in workarounds and efficiencies that allow you to redeploy scarce resources to serve your patients and the public better. So to conclude, I think this is how health systems change. Again, never mind the details here. I think you do need structures to be right, but once you've got a structure that seems to be working reasonably well, leave it alone for a few years. Everyone who hasn't left it alone for a few years in Canada has suffered the consequences, and look no farther than Alberta. Alberta has still not recovered from the amalgamation into one single health services authority. They've lost the CEO, they've lost incredible public trust. There is an inquiry going on in the province, or being called for, about, well, it actually is going on through the Quality Council, about whether providers who have spoken out were unfairly treated and so on. This is chaos. This is chaos and an albatross around the people of Alberta, and certainly an albatross around the government. So if it's working, keep it, and don't expect too much of structural change. You do need policy change, and I think getting the policies right is hard work, and I hope it's all of your work. You need the intelligence that you get from a good information system, the constant, as Camille said, the relentless measurement and reporting, real time, every day, I think is incredibly important. And when I've gone to your conferences previously and seen your wonderful data from the QUIP program and so forth, I mean, it's heartening to see real data generated by a health system that people are using every day. But the whole point is to change the culture. And we have a massive job in cultural change. I'm hoping that the coming period of restraint will actually be an assist to cultural change. It wasn't in the mid-90s because we didn't have the tools. I think due to people like Paula and others, we have more tools now to do that, but I truly hope it happens. And the final message I would leave you with is that, you know, if those of you who grew up in the late 60s, as I did when I was coming of age, you know, there was always the phrase, when there was a great ferment going on politically, and the people who hated change always talked about outside agitators being responsible. I think you should be inside agitators. I think you should agitate the hell out of the healthcare system all the time. And make it your point that, as a PDSA, every time you see something that is fundamentally stupid, organizationally or from an incentive point of view, put it on a storyboard. This is dumb. And when you get a fair number of them, you should have a huddle for 15 minutes to workshop in 15 minutes how you would fix it. And you know what? I think your collective wisdom, your wisdom on the unit level, your wisdom as an individual, you will actually come up with solutions that make perfect sense. We tend to, in the quality movement, restrict the PDSA stuff to real work for patients. But if we PDSA'd and QI'd the policy environment, I think the health system would change much faster than it does now. And I hope there's a little part of your day when you release time to care, that you can care about policy as much as you care about the on-the-ground work, but I think you will move mountains. So I will leave it there, and back to you, Paul.